Good evening, everyone. Today we have Dr. Rashma Mohammed. She is a psychiatrist based at UK. She is going to be with us with a regular routine Back Me webinar series, um, especially concentrating on the empowering the counselors. A warm welcome to you, Dr. Rashma. We are very glad that you are with us in this evening, which is India. It is evening and probably morning in the UK. And amidst the COVID challenges, you are with us. We're very happy about it. And we have a few of our counselors as participants for this webinar. Dr. Linga Devi, we welcome you, and we would um, express our wish to introduce the speaker.
Thank you, Dr. Puneet. It gives me immense pleasure in welcoming Dr. Ashma Mohammed to Back Me webinar series on the title, which is called as Perinatal Mental Health, Mother and Baby Wellbeing. Dr. Ashma graduated from Sri Ramachandra Medical College and Research Institute here in Chennai, India, and went to UK to pursue her post-graduation. She is a member of the Royal College of Psychiatry in UK. For the past 10 years, she's had varied experience in different subspecialties of psychiatry. But what drew her most to perinatal psychiatry was the immense satisfaction of being able to support mothers who have mental health issues at extremely sensitive period in their lives. She was and is still an active part of the new setup of perinatal services started in her hospital in 2018. Dr. Ashma has extensive experience in dealing with eating disorders, forensic psychiatry, and learning disability. Her work on improving patient safety for women of childbearing age who have been started on a drug called Valpray was nominated by the Royal College of Psychiatry. She has also been part of many volunteer projects involving reskilling refugees, psychiatric education, setting up support groups for carers, and health education for people with learning disabilities. Having had the wonderful chance to know Dr. Ashma personally, what strikes most is a pleasant personality, calm demeanor, reassuring voice, and an immense passion for her work. It is indeed a pleasure, Dr. Ashma, to introduce you. And we welcome you to a Back News webinar series. Kindly share your screen and present the session. Thank you. You can see the screen, Dr. Ashma.
Okay. Thank you very much. Thank you, Linga. That's very kind of you, and I'm, humbled by your introduction. And so, a warm welcome to everyone here. It's an absolute pleasure to do this session for you all. I believe people like yourselves can really make a difference to this specific population of women. So, stay tuned as we explore this topic, perinatal mental health, together today. Are you still able to see my screen?
Ashma? The first slide, yes.
Yeah?
Yes, the second slide, yes.
Okay, thank you, Linga. So, as by definition, perinatal mental health problems are those which occur during pregnancy or in the first year after the birth of a child. However, the perinatal frame of mind is much more than this. What I mean by this is you're not just thinking about the women's mental illness, but also developing the ability to think about the mother's needs, the infant's needs, and the mother and infant relationship, which we call attachment or bonding. So these are three distinct areas that you should hold in mind when you are seeing a perinatal woman. Having this holistic view is one thing that I would like you to achieve from this session today. So in this triad, we should be also considering the father's mental health and how this can impact a mother and a child. So this is something a bit more futuristic. So something that you can always, not hesitate to, ask about the father as well. So, what are the views of World Health Organization about perinatal illness? It has been identified that worldwide about 10% of pregnant women and 13% of women after childbirth experience a mental disorder, and mainly depression. In developing countries like India, this is even higher at about 15.6 during pregnancy and almost 20% after childbirth. In untreated and severe cases, mothers are at an increased risk of suicide. In addition to this, the affected mothers, they cannot function fully. As a result, the child's growth and development may be negatively affected. So WHO recognizes that maternal mental disorders are treatable. It identifies that effective interventions can be delivered even by well-trained non-specialist health providers like yourselves. So, why is perinatal mental well-being so important? And is it money and effort well spent to provide care for this population? Absolutely, yes, because research shows that from the time the fetus is conceived to the first 2 years of a child's life, whatever events that happen to the babies lead to structural changes in their brain. And this can have lifelong, impact on the child. This is why the first 1001 days are critical. So brain development is not just about, the genes being passed on, but it also depends on the interaction between genes and the environment that the baby grows in. So the love and nurture by the mother is hardwired into the brains of children even before they are born. So apparently, a baby's brain increases in weight from 400 grams at birth to 1000 grams at 1 year of age. And the connections in the brain are created at almost at a rate of a million per second. So there is, clear and compelling evidence that this is a significant phase in a child's life, and it's an age of opportunity to provide the best start in life for a child. So, what happens during this period will lay the foundation for the child's future health, well being, learning, earning potential. It also makes them resilient and adaptable. And these are very important competencies they need to thrive in the world. So, by looking after the mother, we are looking after the child. And the benefits will last a lifetime and will carry on into the next generation. So if maternal mental health is affected, you can see the number of negative impacts it can have on the child, ranging from obstetric complications such as preterm birth, placental insufficiency, low birth weight, to bonding issues, to behavioral problems in the children. So this is a statistics slide. So most of my statistics in this presentation are based on studies in the UK. This is because this area is very much understudied in India, and it has still not got the importance in the health service that it needs. I assume that these figures will be more in India given the stigma around mental health and lack of services available. So if you look here, 30% of women never ask for help. They don't tell the health professional how they feel. And 28% of mothers with mental health problems have trouble bonding with their child. And 23% of maternal deaths are because of maternal, mental illness. And if you look at this pie chart, it shows that maternal deaths due to psychiatric conditions is the second biggest chunk next to malignancy. This is stressing why we need to actually skill people like yourselves to help these women receive the right help at the right time. So, I'm going to talk about some of the myths around parenthood, which are very unhelpful. It's assumed that, pregnancy and parenting should naturally come and very easily come to women, like we know it all. It's not the case. Pregnant women glow, objectifying women, and the pressure this puts on body image when a woman's body is undergoing so many changes. And yet, most of you would have known most of the celebrity women go through this a very how stressful this must be for them. And good mothers don't get depressed. So by saying that, You're dismissing the mother's feelings. You're putting a barrier to her seeking help. How can you be depressed if you're having a baby, but you have such a beautiful baby? All these comments make the women feel like she's ungrateful for what she has. So, what are the risk factors that make a woman more susceptible to mental illness? So, some personality traits, such as anxious personalities, perfectionists, they can be a little bit more prone to developing mental illness in the perinatal period. An unsupportive spouse is a very important risk factor. Poor relationship with her mother, mixed feelings about motherhood. This is very common in working age women who have to give up their role as a working woman to adapt to become a mother. If the woman has a history of physical, emotional, or sexual abuse in the past, during pregnancy this can get evoked, and it might have never made it to the surface otherwise, but during pregnancy it all comes to life. And drug and alcohol issues in the family. If, say, supposing the pregnancy is unwanted due to financial reasons, due to cultural reasons, or due to the gender of the baby, so that's again going to increase the risk. Complicated pregnancy or delivery or previous traumatic childbirth, infertility issues. I have found that this specific women who have infertility issues can be very highly prone to developing perinatal illness. So you need to be doubly aware of these people. Yeah. So a baby who's unwell can increase the stress for the mother. Stressful events like a death, divorce, abortion, stillbirth can all, increase the risk. So look out for these risk factors so you know whom you have to keep a close eye on. So, about 27% of women felt it was normal to have mental health problems. And most of them feel anxious and low. But this is how we all, if people have given birth, they will relate to this, that, we all feel a bit anxious, we all feel a bit low. But if it's happening most of the time, then it's time you get help from the health professional. So, as psychologists, counselors, or even psychiatrists, how can you help prepare this women undergo motherhood? So, help her to first of all accept her pregnancy by validating that it is going to be a huge adjustment for her and her family. Secondly, identify what her parental role is, what she would be doing, what she's looking forward to in her role, and they set very realistic expectations. Then talking to her about the relationship she shares with her partner, how that can be strengthened to support her, and about sharing parental responsibilities. Then a main thing is education on what to expect during childbirth. This is very important, especially for first time mothers. This can make them less anxious, more prepared to expect what is to come during childbirth. Planning on coping mechanisms to manage fears around pain. Possible law, explain to them that you might feel a little bit loss of control. You can feel that your self-esteem is a bit lowered because you will have intimate examinations. You might feel a bit out of control because the birth plan is not going to necessarily go as planned. We all know we plan for normal delivery, but it can go any other way. So it's important that you help the women prepare for it. So, what are the mental health problems women experience during perinatal period? So, this is a spectrum of disorders. It can range from mild to severe. So, what you will be coming across is mostly in the mild range and the moderate range. And it is not going to be possible for me to cover all of these disorders, but I will talk about uh, what will you will be encountering the most common ones. Yeah. And I also want to bring to your attention that postnatal depression should not be used as a generic term for all types of psychiatric disorder in the postnatal period, because there is a risk that other serious disorders, particularly like postpartum psychosis, can be missed. So moving on, over half of new mothers experience something called baby blues. So, this is a normal phenomenon. It is not pathological. It is not a disorder. It's a normal phenomenon. Most of the women who have given birth can relate to these feelings, that the moms can have mood swings, can overreact to things, they can become easily tearful. So this happens immediately after birth, and it can last up to 10 days. And these are normal feelings, which is due to the hormones, adjusting itself to the, fact that you're no more pregnant and your lactation hormones are starting to secrete. So your body is adjusting and you can have these emotional challenges at that time. So, but these are women who 15 to 20% of women with baby blues may go on to develop depression. So now we will watch a little video. If it is working, well and good. If not, Linga, can you help me with that, please?
Yeah, sure.
Thank you.
If you can see my screen, just let me. Can you see? Can you see?
Uh, Puneet,
Can you see, Ashma?
I cannot see, but you can play it for the rest of them. If everybody else
No,
can.
Yes.
no. Then you can't, is it? Okay, I'll just find out. Doctor, can anyone see the
Doctor,
screen?
just stop sharing, no?
Ashma, you have to stop
Dr. Ashma.
sharing.
Yeah. Dr. Linga, play the video.
Okay.
Birth is often an amazing time
You
for
can
most
hear?
people. It is also normal to feel overwhelmed by the whole experience. New mothers can
Volume
be
increase
sleep
little volume.
deprived, and it's very common to feel emotionally distressed or upset about 3 to 10 days after giving birth. This is called the baby birth is
So I got published in Forbes.
Now that was really something.
If it's not working, that's fine, Linga. We can move on.
Can you see, Ashma?
No, Linga. We'll move
Ashma,
on
can
to
you
the
see?
slide. We'll move on to the slides. No problem.
Can you see?
No, Linga. We'll move on to the slides.
Cannot see.
You can share your screen, Dr. Ashma.
Okay. Are you able to see?
Yes.
Okay.
Ashma, can you see the? Can you see? Can you hear me?
Yes, I can hear you. Yeah. You're able to see my screen, yeah?
Can you hear me?
We can hear Dr. Ashma. We can hear you.
Okay. So
Screen.
I'm gonna now move on to postnatal depression. So postnatal depression is which occurs after childbirth, but women can also experience depression when they are pregnant, which is called antenatal depression. So both are important to diagnose and treat. So about 1 in 5 mothers are affected by this, and the symptoms should be present for at least 2 weeks to meet the diagnostic criteria. The 3 core symptoms of depression are a persistent feeling of sadness and low mood, loss of interest in the world around you, then there's lack of energy, feeling tired all the time, trouble sleeping. I've highlighted it in red because in my working experience, this is a common symptom and mostly the first symptom that the mother will mention. Therefore, please tell the women the importance of sleep if need be to see a doctor and can prescribe a medication for her. They can also experience like that they are unable to look after their baby, problems with concentration, loss of appetite or an increased appetite, feeling very agitated, irritable. They can also have feelings of guilt and hopelessness and self blame. And it's also very common for mothers who find very difficulty in bonding with the baby. So they will literally say that I find no enjoyment when I hold my baby. And also, it can, the more severe it becomes, you can see that, the mom can start having frightening thoughts like, suicidal thoughts or thoughts of harming the baby. So these are very important things to elicit when you're speaking to these mothers. So if you see, this is called the Edinburgh Postnatal Depression Scale. It's a rating scale which is used for screening for depression. It's only a screening questionnaire. It's not a diagnostic one. You can administer it from 4 weeks after childbirth. It can also be used to screen antenatal depression. So the mother is asked to check the response on how she's feeling in the previous 7 days. It comes in different languages. You can Google search it as well. So there is some work done to be specifically adapted it to Indian population, but I don't think it's ready yet for that. So if you look at this questionnaire, so in particular, the 10th question, which asks about suicidal thoughts, if the mom ticks yes to it, then you need to uh, get the help of a psychiatrist because she might be moving on to the severe range of depression. So how does, a woman with depression can come and tell? She won't come and say, I have low appetite, I have, I'm feeling low in mood or something. So she might come to tell you that, I have, there are some of the common phrases that she might be, telling about the negative thinking pattern that's going on for her. So she might say everything is an effort. Uh, if you can name those feelings for her, do you feel like a failure? Sounds like you're feeling helpless and hopeless. They will feel much more understood if you name those feelings for her. And always, always remember to explore risk about suicidal thoughts, any harm to the baby. So, I usually ask it like, my question may sound odd or uncomfortable, but some women during this time can experience thoughts of harming themselves or their child. Do you have such thoughts? So that kind of normalizes it for them. Okay. So why is it important to ask? So you can refer them to a psychiatrist. So also because maternal deaths by suicide are absolutely preventable. So you need to ask those questions because you can get them the right help. So 82% of the women who died by suicide were by violent means. The most common method was by hanging, falling from height, and being hit by a train. So it's very unusual for the baby to be included in the suicide, but it can happen when the mother sees no future for her and the child. So the most risky period is the first 6 weeks after childbirth. And according to a study done in South India, it said that conflict in the family and domestic violence are two major risk factors that push these women to suicide. Next, we move on to anxiety disorders. So this can be a common condition that you will be dealing with, and psychological help is very effective in this condition. So instead of pregnancy being a joyful experience, it can become a worrisome and a fearful event in a few patients, and that's the time when they require treatment. So majority of the women are able to cope with these fears and anxieties by self-help, by social support, but some will go on to need treatment. So I particularly highlighted tocophobia here. It is also an anxiety disorder where the mother has an immense worry, fear of childbirth. So there are two types of tocophobia: primary tocophobia, secondary tocophobia. Primary is a fear of childbirth in a woman who has no previous experience of pregnancy. And secondary tocophobia is a fear of childbirth developing after she's had a traumatic previous pregnancy. Both of this condition can be effectively treated by talking therapy. So now I'm going to talk about maternal obsessive compulsive disorder. So maternal OCD is something that in my experience that I have, which was new to me. I didn't think that it was that prevalent actually, but I've seen a lot of women, go through this. So, many of the pregnant women and new mothers have a normal and a helpful increase in obsessive compulsive symptoms. So, most mothers feel that having a baby is a huge responsibility. They have to be more careful about avoiding risks in pregnancy and after birth. So, but many mothers do not find this to be a problem. But for some mothers, this worry can worsen over time, and it can start interfering with her functioning. So she might be spending on these thoughts and these compulsions for more than an hour a day. Then that's where you have to start thinking this is going into something that needs treatment. So, for example, I had a mother who was aged 40. So, she had previously lost 5 pregnancies due to placental antibody. So, you can imagine how precious this pregnancy was for her. So, she was presenting with very high anxiety, fears if she's eating the right food, if she's doing the right exercises, excessively focused on fetal movements, and she needed, frequent ultrasound to check, the fetal movements. She delivered a healthy baby, but she was having perinatal compulsions now. So she was checking the baby every 5 minutes by literally waking up the baby to see if it was breathing and alive. But she ultimately responded very well to CBT and parent infant relationship therapy. So another common symptom, another example of a lady whom I met was she had a fear of touching the baby inappropriately. So she was avoiding nappy changing. Again, this woman had intrusive thoughts that she felt so trapped to disclose these thoughts because of the fear of being judged for having such thoughts. And she was from a cultural background as well where it was very difficult for her. So don't be alarmed or judge the women if they have such thoughts, but offer to listen to them and provide the right help. So this is another rating scale that you can use again. So the PHQ is for depression, whereas the GAD-7 is for anxiety. So it is not just particularly for perinatal women. We use it even for other people with anxiety and depression. But it's a good one to help you pick up, if the women needs extra help. So put a chart here. If you score it, you can, see which range she falls in and what are the treatment options for her. So I think I'm just gonna move on.
Ashma, I can play the video. You can stop sharing. I'll play.
Okay.
This is fine. I'll play the first one as well. Both are on the screen. So I'll just play the first one and then this one. If you can see
often an amazing time for most people. It is also normal to feel overwhelmed by the whole experience. New mothers can be sleep deprived, and it's very common to feel emotionally distressed or upset about 3 to 10 days after giving birth. This is called the baby blues, and it usually goes away. However, in about 10 to 15 new mothers out of every 100, the symptoms of depression are much more intense and last for more than 2 weeks. And they can impact on things such as how you bond with the baby, as well as how you're able to function as a new mother. This is, of course, very distressing, partly because everyone expects you to be happy after you've just given birth. The important thing to realise, though, is that this is a disorder and it can be treated very effectively. In mild forms of postnatal depression, all that may be required is seeking help, either from friends and family or from your doctor. But in more severe forms, you may need to try talking therapies or antidepressants. And in many cases, this may require specialist treatment by a psychiatrist.
Even though my little girl was born healthy, after a long and painful labour, I felt physically raw and vulnerable and emotionally completely wrecked. 24 hours later, I went home with my baby and felt completely overwhelmed. I didn't sleep, even when my baby was sleeping. I found breastfeeding painful and difficult. I was often in floods of tears when I was feeding her. I felt scared and confused. Even though my little girl was born healthy, after a long and painful labour, I felt physically raw and vulnerable and emotionally completely wrecked. 24 hours later, I went home with my baby and felt completely overwhelmed. I didn't sleep even when my baby was sleeping. I found breastfeeding painful and difficult. I was often in floods of tears when I was feeding her. I felt scared and confused. I didn't know what was normal, and I thought that this was just what all new parents must be going through. I put on a brave face and told everyone, including my partner, that everything was fine, even though each day I felt like I was falling apart. Over the next couple of weeks, I continued not to sleep, even when my baby was sleeping, and I began having scary and intrusive thoughts. A friend came to visit and asked me how I was going. I broke down in tears. I told her I wasn't okay. My partner and my friend helped me get the support I needed, which included calling the Panda helpline. Once the right supports were in place, I started to feel more like myself and more connected to my baby. I even started enjoying being a mum. My daughter is now 4, and even though some days are hard, I absolutely love being a mum and I feel deeply connected to her.
I think that's it. Ashma?
Yeah, thanks, Lina. I'm just going to share. Are you able to see my screen?
Yes, we can see.
Okay.
Yes, Ashma, I can see a slide.
Even though my little girl was born.
Are you able to see now?
Yes. Yes, we can see. It's gone.
Yeah, we can see a slide.
Yeah, just give me one moment. Now, Linga?
Yes, it is visible.
Ashma?
Present? Yeah, are you able to see?
Yes, we can see.
Ashma, we can see a slide, but we can't.
No audio?
Ashma.
Yeah, Linga, are you able to see the screen?
Yeah, we are able to see the screen, but we couldn't hear you.
Okay. Yeah, sorry about that. So I'm going to talk to you about now PTSD, which is post-traumatic stress disorder, and birth trauma. This is also, this affects about 4% of women. For example, women had a baby and the baby went blue in her hands. So the baby was rushed to the neonatal ICU, and how this event triggered PTSD for her. So she started having flashbacks of the baby turning blue. She avoided holding her baby. She was all the time hyper vigilant, and she just didn't want to be anywhere near the baby because it brought up very difficult memories for her. But this responded very well to trauma focused therapy, and take taken this is very effective because some mothers, because of this experience, they never want to have another child, but giving this trauma focused therapy helped her, help women to overcome this difficulty. Oops, it's gone again. Are you still able to see, Linka?
Yeah, we can see.
Yeah, okay. So, postpartum psychosis. This is a very severe mental disorder, and it needs psychiatric assessment and a possible admission to hospital for treatment. So, you might not have to deal with these women, but what happens is it's important that you recognize this woman is having postnatal psychosis and get her the right help. So usually these women have a history of bipolar affective disorder or schizoaffective disorder. There's a strong family history of psychosis, and they may have stopped taking their medication because of the fear that it may harm the baby. So this is a very severe psychiatric condition, and it's an psychiatric emergency. So usually these women, the most common thing is family members might say that something is not quite right with her. She's not sleeping very at all, or very poor sleeping, irritable. She's very muddled in her thinking. She can also start to experience very florid psychosis symptoms like hallucinations, delusions, and her mood can be quite elated or quite low. And you can see that, it's very rapid, and the picture changes very quickly in these women. So I'm going to talk about, red flag signs. So red flag signs are so a recent, you have to be mindful in postpartum psychosis that the mental state rapidly changes, and then, new symptoms can be presented for the first time. And the mom can start experiencing violent self-harm thoughts to herself or to the others. Then there is a expression of that, she's not a good enough mother, and this is not just that it comes and goes. She will very strongly believe that she is incompetent to be a mother. And these are red flag signs, and you need to get her to it's a psychiatric emergency for a probably to start antipsychotics or an inpatient admission. So now we are going to talk about attachment. So remember the triad that I spoke about in the beginning: mother, child, and the mother and baby, relationship. So this is attachment. So it's the name given to the bond a baby makes with its caregiver, which is mostly the mother. So there is long-standing evidence that a baby's social and emotional development is affected by their attachment to their parents. So babies are very vulnerable to abuse and neglect, and they might, respond or show you in a way, that, like, by crying a lot, they cannot be soothed easily. They are always on alert. Like, if you look at the baby, it looks frightened, and it does not respond when you interact to the baby. And it might experience poor sleep, the baby is not feeding well. So when all these issues mom is telling, start thinking about, is there an attachment issue here? So this picture that I put here, you can see the mom is not giving any eye contact to the baby. This is a very classical presentation. If you see, the mom will just be like a robo around the baby, so literally there's no connection or bonding that goes on. So what happens when attachment, when a mother is unwell? So what happens is she may be disengaged. She's not tuned into the baby's needs. She may not interact with the baby. And if, and say, supposing the mother is irritable and hostile, it can create a fear and anxiety in the child. And it can have a long lasting effect on the child's view of the world itself. So, what are the psychological interventions that you can provide for, perinatal women? You can start off with the low key ones, like the relaxation techniques, mindfulness, patient education, CP. There are a number of interventions that you can offer, and it depends on the mild to severe, moderate range where she falls under. So it can range from CBT to trauma therapy. For attachment and bonding issues, in the UK, we offer something called parent infant relationship therapy. So you can enroll in such a training and adapt it to the Indian population. That's something that I would strongly recommend you as counselors and psychologists to look into that. So again, again, setting realistic expectations for her. There will be happy times, but not so many happy times as well. So setting that realistic expectations is very helpful for the women. I'm sure a lot of us can relate to that picture there. So, it's also a very golden period for, a women, because the women is very much geared into giving the best to the child. So she's very motivated. She wants to do, she wants to, even, if she's never had medications, if she's never had, talking therapies, if you tap into her at this time, she might be more than willing to do anything, because she wants to give the best for her child. So use it as a good opportunity for her to engage. So when you see these women, it's important to bear in mind, what are the women's wishes and values. remember the cultural beliefs, what are her religious beliefs, because it is all going to help her, or to make her decisions. And always think about, okay, what are the implications of the treatment on the mother, on the infant, and on the attachment, and who is she listening to, and who is having an influencing her decisions. It can be the partner, it can be her mother, her father, or someone elderly in the family. So try and bring them into the discussion as well, educate them as well, which is very important. And then perinatal women have very different specific needs to the general population. So don't just think that depression means it's the same as any other depression. Perinatal women are more, they need to be functioning at a much higher level, because they need to look after themselves, they need to look after the baby, they might have another baby. So you need to get them to a very good functioning level. And most often, women in India, they in the perinatal period, they can come and tell you that they have somatic symptoms, pain here and there, or they can present with functioning problems. I'm not able to do this. They might not clear cut come and tell I have low mood. So watch out for that. So also bear in mind that the women could have developed diabetes, hypertension during pregnancy, how this can affect her mental state, and if she is on a psychiatric medication, whether she's taking it or not, what are her fears on the effect of medication on the baby. So have a chat about that. So, this is a very important slide. So, the risk of not getting treatment is far more than taking medications or talking therapy. So, a well mother is important for the child's development. That needs to be borne in mind. So, always encourage that you are better off taking medications or getting treatment for your illness rather than not taking it. So some, I have looked into what has been happening in India around perinatal. So there are two things that I came across, which I thought was really good. One is in Kerala. It's called Amma Manasa, or Mother's Mind. It's run by the Kerala government, and it is looking at integrating mental health into routine antenatal and postnatal care. You know how stigma, mental health has its own stigma. So women are more, willing to come and talk about it when they come for their routine checkups. Then you have the NIMHANS in Bangalore, which is a very advanced, has mother and baby unit. I don't know if you know Dr. Prabha Chandra. She is a very famous perinatal psychiatrist who also gives talks in the UK. So what is the scope in India for perinatal services? So we need to, there needs to be work done to raise perinatal awareness. And today is one such day which BACME has, done it today. So if we need to raise that awareness, we need to develop perinatal services for women in India. Even when I was searching the net for pictures or videos of Indian women speaking about perinatal health, I could hardly find any. That's why all my pictures are about white women and people in the UK. So that low and middle income countries like India have a higher prevalence of perinatal health problems. There's a higher rate of maternal suicide, and this is mainly driven by marital conflict, interpersonal violence. So addressing those two issues are very important as well. And equipping the existing counselors and psychologists like yourself, as important points of referrals for secondary care. Then also sensitizing the obstetricians, pediatricians will ensure that these women do not get missed during the antenatal and postnatal periods. Because of the stigma, they may hesitate to make the first step to see a mental health professional. So sometimes the obstetrician and pediatrician should pick up that this women needs a mental health, support, and refer them on appropriately. So don't forget about the dads in this. They are very important in a woman's life. And they also, around 10% of dads actually experience depression after a child is born. So don't so it's important that you ask how he is doing and signpost him to see a doctor if you think he needs help. So as you know, pregnancy is an amazing thing. So let's all make it that way for all the women we care for. Yeah. And my final take home messages for you all is that it's a very time of opportunity. It's a time of change in a woman's life, but it's also a challenge. You need to be very clear in your communication to these women, because you need to give her the right information. You also need to communicate with other professionals involved in her care, and you have to strengthen her network. Don't forget about the father in this picture. Remember the triad, the perinatal triad that I told you about. It You need to hold the baby in mind. So it's about the mother, the baby, and the bonding. And when you're dealing with so you might it's very important that you also tell the mother that it's getting treatment is far more better than not getting treated for the child's future. So I'll stop there. And yes, it's thank you, Puneet, and thank you, Backme, for giving me this opportunity. And it's an amazing time to have had, opened up this conversation about perinatal mental health. I'll take questions from now. I'll stop sharing my slides.
You can have a thank you back, me, Ashma.
Yeah. Okay.
Yeah. Thank you, Ashma. I think you have elaborately spoken about the topic perinatal mental health and mother and baby well-being, and helping us to realize how important it is to be there for the women at this sensitive phase in their lives, and raising a great awareness about this topic and need to address the lacunae in our current setup as well. I think the take-home message from your talk has been excellently emphasized, the triad on mother, baby, and the bonding, and suggesting ways to empower our counselors to help mothers face this challenge. So, Ashma, you've just tried to summarize such a big and vast topic, which, as you said, only of late, even in UK around 2018, that it has been established in various trusts. And, so we are quite thankful to you for such an elaborative talk. And it has been such an very good information as well. So I will just ask whether Dr. Puneet or Sudha ma'am to speak to you about a few words before we take any questions.
Dr. Linga, we can go ahead with the questions.
Can you see my screen?
Yeah, I can see, Linga.
Okay. So we had a few questions from the participants. So the first one is, what is the role of counselors in reducing perinatal anxiety? You've addressed a few in your topic as well. If you would like to just touch on that, please.
Yeah, I've already spoken about it, but what I would like to, what the challenge here for counselors is the difficulty to distinguish between normal anxiety and a pathological worry. So that's why you can use the GAD scale. It's a good rating scale to see where what her scoring is. Then also look at how her functioning is reduced as a mother, and whether it's affecting her bonding. Then you may want to think about whether she needs talking therapy or medications. Also, if your role is to inform her obstetrician, her health visitor, so that they all can sensitively handle her. You usually, most of the perinatal anxiety responds very well to a CBT approach, to relaxation techniques, to mindfulness therapy. So we can, what I've found is, it's a little technique like a breathing exercise is very handy for a mother. It is one of the most overlooked, but a very helpful stress management tool. So tell her that a controlled breathing, it will reduce the fear chemical in your brain. So giving that tool to her, teaching her that would be a very helpful thing. So that would be my answer.
The next question when participants are enrolled was, what has been the highlight of your experience in dealing with these patients from your experience?
It's for me, it is about being there with the women in her journey to motherhood, and trying to give her the best possible experience for her, as it's a very special event in any women's life. So I thoroughly enjoyed that. And involving other professionals, it's joint work. It's never working on your own with these women. It's about connecting with the obstetrician, the pediatrician, with health visitor. So forming that network around her, I like that, experience as well. That's me.
Okay, 1 second. So the next question is, what is your advice to the first-time working mothers first-time or working mothers on strategies to cope with family and work?
Okay. So I would say for first time mothers or working mothers, is it's a time to put yourself and your baby first. Everything in life can wait, including work. It's like airlines, where you get the safety message, put your oxygen mask first before helping others. So that's the message. So, it's important that you share your parental responsibility with your husband, with other members in the family, especially for the first 6 to 8 weeks after birth. Think about part time working so you still feel fulfilled in your work role. Seek help early. You know, getting support from other women who are in the same point of life as you are can be very, very useful. And empower dads. Most of the time, what I find is men want to help, but they do not know how to help the women. So let them know and agree on what they can help you with. Empowering dads is empowering the whole family. So keep the, I think that would be my strategies.
Thank you, Dr. Shma. Usually after the birth of second baby, the first child is given less attention. Is that going, in your experience, going to have an impact on the first child? And what are the ways to prevent, if so, you think?
Okay. So, having a second child and handling, two kids can be overwhelming at first, but having a good organized plan is usually works well. So you can, you can tell the women that, one positive thing is that she's done it before. So she has the ability, she has the knowledge about, what is breastfeeding, what is, how to change diapers, handling a, minor illness for the child. So this will become a second nature for her. So give her the confidence. You've done it once, so you can do it, the second time. And then, then your first child may, start to show symptoms like, regressive behaviors, like they can start sucking their thumb, bedwetting, wanting to drink from a bottle, using baby talk to get your attention. So these are all common things that you can pick up. These are problems usually short lived, but with a little bit preparation of the older child, they will start welcoming the child. But you have to make sure that you explain to the child that a newborn will cry, will sleep, will need a lot of diaper change. So you are, kind of tuning that baby to what to expect. Even though there is a second child in your hand, make sure that you have a little, a good amount of time for your older child on a one-to-one basis, so that your newborn is being looked after by someone. Always make time for your first child as well, or the other children, individuals.
Yes, that's true. And sometimes, tuning the little kid right from, the pregnancy itself, that there's going to be a sibling, will help the firstborn child to adapt to the birth of a new baby as well. Thank you, Dr. Ashma. So the last question would be, how to prevent suicidal tendency after delivery of the baby? Obviously, you've covered this in most of your talk, but if there is any highlight, which you want to share with the participants, please go ahead.
I think, avoiding suicidal tendencies is, why are you thinking about, suicidal tendencies? Is it the mother, uh, going into severe depression? So if she's having previous mental illness, then you need to think about a good pre-birth planning meeting. So that's what we call it here. So you have something called a pre-birth plan. So you plan, okay, if you start having these thoughts, this is the time you seek help. And what are the other people around you can start seeing signs and symptoms in you early on. So actually writing it down helps the women, and then they know what to do. So it gives them a little bit of control over their illness and empowering them to take in charge of their illness and get treatment.
That's an excellent, advice. Something as you rightly pointed, there's a lack in our setup, and trying to, concentrate on this pre-birth planning is vital for, be it new mothers, young mothers, or high risk, mothers at later stage as well. I think everyone needs help, even if they're professionals as well, even doctors themselves. I think they need. So thank you
Yeah.
so much for bringing it to light during our session today, Ashma. Um,
Thank you. Linda. Thank you for being a fantastic moderator.
Yes, we are very happy that Dr. Linga could really moderate it well, and see that all the videos are played and make you as comfortable as possible. And I'm happy about it. And we have tried to bring in this topic to the counselor's mind. Hopefully, they bring in and more of awareness among the women which they're coming in during their practice, and then try to bring in some counseling aspect as you have suggested through your talks. I'm very thankful to you, Dr. Ashma, for being here for us. And over to Dr. Linga for the concluding remarks. And yeah, thank you.
Thank you, Dr. Puneet, and thank you, Sudha ma'am. Thank you, Linga. It's been an absolute pleasure, and I will let Linga have the last words here.
Thank you, Dr. Ashma. As a few of the participants have sent messages thanking you and saying that it's been such an useful information and highlighting the importance of this topic. And I'm sure this is just the beginning of many more of such discussions. And thank you, Bakmi, for helping us to use your platform to bring out this important issue. I think. Thank you. Is there anything Sudha ma'am wants to say?
Thank you all.
Thank you.
Bye bye.